Right, good afternoon, everyone. Hopefully you can hear me fine. Thank you for joining us. My name is Mahmoud Begum, and I'm really pleased to be chairing our first session in our new Neighbourhood Insights series. And this is a new series from the Strategy Unit. If you've been with us for a while, then you'll know that we've been doing Strategy Unit Insights for a good while. Before we get started, just a couple of really quick practical points. So one, cameras are off and mics are muted, and they will remain that way throughout the session. But there is a Q&A function. So if you've got any questions, just pop them in there and we'll pick them up during the session, and we'll answer them in a Q&A segment that we've got at the end. Just a little intro to Neighbourhood Insights. So I'm going to start by saying a little bit about why we've actually created this series. So shifting care from hospital to community has always been an ambition in the NHS for decades. I'm sure lots of you have been in the system to know that long enough. Yet despite repeated sort of policy attention, and progress has been kind of slow, and it's been difficult to actually sustain, and hence the multiple reforms we've had. At the same time, the idea of neighbourhood health has now returned to being very strongly the centre of our national policy at the moment, and the ambition to organise care around local populations, communities and prevention is once again front and centre of what we find ourselves looking at. So the question we've been asking in the strategy unit is, how can evidence and analysis actually help make that shift more successful? Through our work across a range of sort of national and local programmes, including the National Neighbourhood Implementation Programme, the New Hospitals Programme, the National Communities Strategy, and other collaborations that we've had with various systems and policy teams, we've been developing various tools, analysis and insights that we think can actually really help people working on these questions that I've just gone through. So Neighbourhood Insights is really about sharing that work more widely and creating a space for the conversation with those who are extremely experienced in the system, are working in it and know lots about this stuff. But the series is not designed to be technical or intimidating. We know some of the things that we're going to be looking at is to do with modelling and policy analysis and evaluation. But the aim really of these sessions is to make our insights more accessible and useful to a broader audience. And for those of you who are interested in some more of the detail, we can share that with you separately, or you can request things, and there's various reports and tools we've published and share openly that you can access. So hopefully, whether you're working in service design, clinical leadership, commissioning, strategy, policy analysis, or even in neighbourhood delivery itself, we hope that there's going to be something useful and helpful in the work that we share. And importantly, really, really importantly, please don't hesitate to ask questions, including the really basic ones. Often those are the most useful questions for everyone in the room. And even at the unit, we often find ourselves revisiting the basic questions when we're working on some of these really tough, complex things. So for today's session, it's really about setting the scene for the whole series, really. And in many ways, we're looking at two very large forces that shape health policy. And the first is demography and how populations are changing and what that means for future demand of health and care services. And the second is innovation and technological change, which has historically shaped how care is delivered and how often systems, how they're organised, what they sort of prioritise, the new transformation projects and all that sort of thing. And in a sense, these two forces create interesting tensions and unavoidable ones. So that's what we've sort of chosen to frame this session with. Demographic change often pushes us towards sort of thinking the need for more stronger community-based care because demand is rising and populations are aging and prevention becomes even more important. But innovation and technology can sometimes pull in different directions, reinforcing hospital-based care or creating new patterns of service use. So that creates a different pull in a different direction. So today's session, we're going to be looking at both of those. Firstly, taking a look back to understand what previous reform efforts can teach us. And then we'll be taking a look into the future and looking at what demographic changes could mean for the future of community services. So I'm really delighted to actually be joined by two colleagues who I'm very fond of at the strategy unit. And first we'll hear from Fraser Batty, who's our head of policy, and he's been leading work looking at recent sort of policy history around shifting care and thinking about why previous reform efforts have struggled or failed to sort of deliver sustained change. And he'll also explore what we might learn from that history and what it might tell us about the current push towards sort of neighbourhood health. And after that, we'll hear from Justine Wiltshire, who's our head of analytics and modelling. And Justine has been leading analytical work looking at future demand for community services using demographic modelling and population projections. And that's really to understand how it might change over time. And her work along with the team have helped us really think about what kinds of services communities may need more of in the future and what that might mean for future planning and also commissioning, of course. And so some of the tools and analytical approaches that she'll mention today, we've already shared out, but we'll also come back to revisit in future sessions in the series. So that was quite an introduction, and hopefully everybody understands a little bit more about what we're looking to do in this series. But without further ado, it's with that introduction, I'm very, very pleased to hand over to Fraser, who's going to start us off really by looking back at what previous policy efforts can teach us. So Fraser, over to you.
Thank you, Mahmouda. Let me go through the awkward moments of attempting to share my slides.
The technology we talk about.
Have I pulled that one off? Is that okay?
Perfect.
Thank you. Yeah, well, thanks, Mahmouda. Thanks, everyone. It's excellent to see so many people here for the first event in this series on neighbourhoods. I'm Fraser. I'm the head of policy at the strategy unit. And as Mahmouda said, we've got two presentations for you today that, in a sense, point at big underpinning secular macro trends that really help to set the context for much of what we might think of as neighbourhood care. I'm going to present the first trend. It's huge, and I think it's underappreciated, and in some respects sort of bizarrely underappreciated. And I think if we don't appreciate it, and if we don't address it, then it really will thwart many of the ambitions that we have to shift care from hospital to community. So I'll present for 15 minutes or so. I've given the presentation the title of Swimming Against the Drift, and I hope as the presentation goes on it becomes clear why I've opted for that title. Before I get into the material itself, I'm extremely sorry. I need to give you a little bit of NHS policy jargon. So anyone from outside of the NHS or anyone who didn't previously have this bit of jargon in their mind, I'm terribly sorry. But you need it. So if this is a hospital and that is a community, then the policy aim of shifting care from hospital to community goes by the slightly clumsy phrase, the left shift. And you need that in order to make sense of what follows. The way I would really like to tell this story is through the lens of the Darcy Review. I think for many reasons, and hopefully some of those will become clear as we go, it's a really, really good way of looking at this shift from hospital to community and reasons why, historically at least, it's unravelled. And so to pick that story up then, we all know that when the then new Labour government came to power, it asked Darcy to undertake an independent investigation into the state of the NHS in England. And it's a good report, isn't it? It's good, detailed, empirically strong. There's a annex with sort of 300 charts within it, and it's well expressed, and it's thoroughgoing as well. He looks at the problems of the NHS from many, many different angles, and one of the angles he looks at is the desired shift from hospital to community. And when he does that, here's where he gets to. He says that since at least 2006, and arguably for much longer, successive governments have promised to shift care away from hospitals and into the community. But he goes on, in practice, the reverse has happened. And this is why I needed to give you the jargon. The left shift could, in fact, be characterized as a right drift. It's worth pausing briefly. I mean, it's kind of incredible that we've set a policy aim, a very clear policy aim that I'll say more about in a moment, and in fact have achieved the reverse of that policy aim. So I'm going to look at this question then of the right drift from many different angles. First of all, following Darzi from the policy angle. There are several different NHS policy documents or plans or strategies on the illustrated on the slide there. I could have put on many more. The thing they all have in common is they all express this desire to achieve a less hospital-centric NHS for some of the reasons that Justine will come on to present, largely relating to demography and shifts in disease patterns. So Darzi says going back to 2006, and he's clearly right. I think, though, the lineage, in fact, goes back a bit further than that. And I'm going to show you now a quote from another national investigation into the NHS, which found the following things. They found considerable practical difficulties to be overcome in shifting resources, and in particular, some of these difficulties were seen in the efforts to promote community care, and the investigation goes on. Unless additional resources were made available, progress would be slow. And that's a quote from a Royal Commission into the National Health Service from 1979. And there are other you can go further back. The hospital plan, I think 1962, has got similar quotes in it. Quite a lot of discussion about how we would need to consider hospitals just a part of a system of care, and we would need to boost community-based care. So the policy lineage, in fact, goes back much further than Darzi suggests. And I think this is aging me now. I think every day of my life has been a standing aim in health policy. So for nearly the last 50 years, to shift care. A more recent look. This is from April 2016. This is the General Practice Forward View. Many of you will remember that. Slightly incredible quote here. This is Simon Stevens, who then was the chief exec of NHS England. And in the forward, he writes the following. He said, if anyone 10 years ago had said, here's what the NHS now should do, cut the share of funding for primary care and grow the number of hospital specialists 3 times faster than GPs, they'd have been laughed out of court. But he says, and he's saying this in 2016, looking back over a decade, that's exactly what happened. So again, go back to when Darzi was saying these efforts had began, we've achieved the reverse. What's interesting, though, is here we have a major policy document with the person at the top of the shop very clearly specifying what the problem is, and then we get a series of policies and programs and all the rest of it attempting to reverse that trend. What happened? So he was looking back over a decade. Why don't we look forward now? We can see where those efforts came to, and I'll do that first of all using a chart from a very nice paper in the BMJ from 2025 from Pettigrew and colleagues. This is a very edited version of their chart. I've edited it for clarity. I'm going to show you the decade after when Simon Stevens made his pronouncement. And I'm going to show you, first of all, what happens to the numbers of full-time equivalent GPs, and then what happens to the number of hospital-based consultants. And again, we're looking forward from that point where Stevens is saying we have a problem. The number of GPs, you can see, what's it doing? I mean, it's hardly ticking up. If anything, it has declined very slightly. The number of hospital-based consultants increasing really quite significantly over the period. So again, not to labour the point, it's not as though we don't know the problem, and it's not as though we haven't put in place policies and programmes to remedy it, and yet we're seeing the reverse of what we apparently desire. Staying on the workforce, but from a different angle, very different angle. This is my mum. Nurse Batty, she was a district nurse in Chesterfield in the 80s and 90s. What has happened to her profession over time? The chart I'm going to show you here is from Billy Palmer from the Nuffield Trust, and it shows the number of full-time equivalent district nurses in the NHS in England. In some respects, you might not be able to follow all of the detail on the slide, but 100% you can see the trend. And the punchline really is that we've very roughly halved the capability, the capacity of this absolutely fundamental part of the community-based workforce. And again, you might not be able to see the detail on the chart, but you can see the title, and that's doing a lot of the work for you. The title Billy Palmer gives it is The Lamentable Decline of District Nurses in the NHS in England, and there's been subsequent work on that. So again, we've not built the workforce to achieve the policy aim. That's the workforce. What about activity? The chart I'm going to show you now looks at non-elective admissions, so hospital-based activity, running from 2011-12 up to 19-20, and it's from a piece of work that we've done here at the Strategy Unit. And the thing I'm going to show you is trends in non-elective admissions, but cut in the following sort of way. First of all, I'm going to show you activity that we don't think could be mitigated. So in a sense, the sort of background trend for non-elective admissions over that period. And then I'm going to show you activity that we think could have been mitigated by prevention, by substitution, but by community-based alternatives, community-based activity. So here's the trend for activity that we don't think could have been mitigated. And you can see it ticks up very slightly and then dips towards the end. But activity that we think could have been mitigated by community-based alternatives ticks up really quite radically in comparison over that period. And remember, this is a period where we've been cutting the community-based workforce, primary care-based workforce, and increasing the hospital-based workforce. And then finally, money. This is a chart from Sally Gainsbury and colleagues, again at the Nuffield Trust. And this is different types of investment. I'm going to show you two, running from 2016-17 through to 22-23. The top line, this is money going to acute care provided by hospital trusts, NHS trusts. And you can see over the period, it's flat for a while, then it ticks up, and it ends up around about 20% higher. Money going to community healthcare provided by NHS trusts is actually cut in many of the years, covered in the chart, and ends lower. But it is the reverse of what you would expect if the policy aimed to shift care from hospital to community was being enacted. And that's it for looking at the right drift. I just want to pause briefly though, just to try to just make some assessment of the magnitude of what we're talking about. And I want to do that through a quote, which I think is very powerful, from this King's Fund report by Becky Bard and colleagues. It's a really nice report. It gives you a really good rundown of many of these issues. And they say that the failure to shift care from hospital to community must rank as one of the most significant failures of policy, leadership and implementation in the recent history of the NHS and social care. And it's pretty hard hitting, and I think I would agree with their conclusion, and possibly only you could put the failure to reduce inequity next to that as a sort of historic failure of recent policy. So really we are talking about something really quite significant and really quite big. And the question then, of course, that you get is, well, why? How have these efforts unravelled when we've had such a consistent aim in policy, which is the kind of thing that we would normally dream of in public policy? How, given that consistency, have we not achieved it? And Darzi looks at that in his review. I mean, I should be fair to him. He's he's looking at a million different things. He's not attempting to get a precise diagnosis as to why the right drift is going on. But nonetheless, he does point to some factors, and I think it's very instructive when he does. And how does he explain it? How does he explain the right drift? Well, First of all, he points to the way that financial flows and contractual incentives have operated, particularly within the NHS. Commissioning certain parts of the system by activity and trying to stimulate activity, other parts of the system with block contracts and no incentive, in a sense, to increase activity. And I think the evidence bears him out. I suspect that's true. Darcy also points to the way that NHS constitutional standards apply unevenly. They apply much more to hospital-based care than community-based care. Partly as a consequence of that data and performance measures within the system concentrate very largely on hospital-based care, although there've been good recent improvements in community services data, but I still would say that he's right on that the evidence would bear him out. I often like to say the review is obviously empirically strong and good, but also it is political. His review is a political one, and in one of several shots at Andrew Lansley in the 2012 reforms, the reforms that followed the Lansley Act, Darcy says that the large-scale reorganising of commissioning structures which followed that led to an acceleration in the right drift. And many of you on the call will observe that we're currently undergoing a similarly large-scale reorganisation of commissioning structures. So we will see if that accelerates the right drift. Anyway, I think Darcy's basically right. I wouldn't want to say that any one of those factors is wrong, but I do think he's missing something, and I think he's missing something very big and perhaps for him almost too close to see as well, maybe. And the fastest way I can illustrate that to you is again through a heavily edited chart. This is a piece of work that we at the Strategy Unit did to help launch the Health Foundation's Real Centre. The report is really good. It's a really excellent piece of work. It's called The Bigger Picture from 2020. The chart here is edited from one in the paper, and I'm going to show you the growth in elective procedures and the growth in community services over the period illustrated on the chart. And I'm going to show you also what explains that growth. First of all, I'm going to show you the extent of growth explained by demography. And by that, we mean the population getting bigger or older or sicker or having many more long-term conditions, those kinds of things. So growth explained that way. And then I'm going to show you growth explained by what we would call other factors. So the growth explained by demography for elective procedures in hospital and community-based services is basically the same. There is some growth, there's very little between those two. But if you then show growth attributed to other factors, you can see that the growth in hospital-based elective procedures dwarfs that for community services. I mean, you have to squint hard to see the growth there in community services. And the interesting thing then is when you push into these other factors. So what are these other factors? What explains that astonishing level of growth in elective procedures relative to community services? And what you see is that it's very, very largely a function of innovation. So this is gains in diagnostic possibility, in treatment possibility, in the way you can make particular clinical services more intensive. But it's very, very largely what we're looking at here is the role that innovation plays in macro level resource allocation choices within the NHS across health and social care. And you see that the pattern is tending towards hospital-based specialties and not community-based services. So what I would want to do then is agree with all of Darcy's diagnoses and just add on this huge factor, and I think underappreciated factor, in terms of the way that innovation leads to resource allocation choices. Where then does that leave us? We've had, in some sense, we've had the diagnosis, we've had Darcy's review, we've subsequently then had the 10-year plan, which in a sense is our prescription for change. And those of you who've looked at the plan will observe it's a long plan, there's very much in it, there are lots of initiatives announced, many ideas within it, but I've had it explained to me as containing really just two things. The first is neighbourhoods, which in a sense is the lodestar for the ambition to shift care from hospital to community. And the second is innovation. And my thought on that would be, to the extent that that tension exists, history shows us which way it gets resolved, and it doesn't typically get resolved in favour of the left shift. So I would say, if you follow the logic of everything I've just offered to you, that there is a tension within current policy that we're then going to be living with. So we retained the policy aim for a left shift. We've had it for the longest time, and we still have it now. And yet what we're observing is a decades-long trend that goes the other way, the right drift. And hopefully that helps you see why I gave the presentation the title Swimming Against the Drift. The only thing I would want to just sort of dissent slightly from here is that the word drift makes you think, you kind of get the image of a river just flowing gently by in the sun. And I think it's probably a bit more serious than that. And I think that sets the context for programs like Neighbourhood Health. In a sense, I would say we're not just swimming against a drift, we're swimming against some pretty fundamental trends and pretty strong tides. So anyway, I hope that's useful. That's the first of our big trends. I'll hand back to you, Moda.
I'm here. Thank you, Fraser. I think that overview was really helpful, actually, and even helpful for me. And it really highlights some of the ambition that you've kind of talked about in terms of shifting care that's been present in policy. But it's also difficult, given how you're saying that it's sort of translating in terms of the ambition to actually what we're seeing and the practical change on the ground. So our second presentation hopefully helps take that discussion a little bit further, and it looks at sort of the opposite direction about what then for the sort of future. So I'm going to invite Justine to sort of invite to do her presentation. And Justine's work kind of looks at the demographic changes that Fraser was talking to there, and how that's likely to shape future demand for community services, and what that might look like in terms of the care systems that we design around that. So Justine, I'm going to hand over to you, and if we've done this correctly, this should work perfectly. Right, there you go. Thanks, Justine, over to you.
Thank you, Mahmouda. So now I'm going to take you through some work that the strategy has done around what we might expect the demand for community services to be in future. And in terms of future, what we mean is by 2035-36, that's the period at the end of the 10-year plan. And indeed, the original ask for this analysis was to support NHS England in their work around the 10-year plan. So the first thing that we wanted to consider in terms of what would be the demands on community services in future is what would be the effect or the impact on community services from demographic or population change. To do this, we started off by looking at the current utilisation within community services, and by current I mean in our baseline year of 22-23. And our data source here, it was the National Patient Level Community Services dataset, and what we can see in terms of utilisation, here we've got the average number of contacts per community patient per year, and we show that by the different age groups. So for the younger age groups, actually, they use a similar amount of community contacts, sort of between 3 or 4 contacts per community patient per year. But clearly, when community patients are older, they have a need for many more contacts, more and more as age increases. So having looked at that baseline utilisation, the next thing that for us to consider was how the population in England was expected to change. And to do that, we use the ONS population projections from 2018, and on the chart here we can see the percentage change in population numbers between our baseline of 22-23 and our future year of 35-36. This shows that proportionally the largest increases are in the oldest age groups. So, for example, by 35-36, the number of people in the population who are aged 85 and over, that's expected to increase by 52%, so half as many people again in that age group by the time we get into 35-36. So then we apply our baseline utilisation to the population of the future, and we think about how community service contacts might need to increase in future. Overall, the growth in community service contacts is 20%. So across all age groups, community contacts need to increase by 20%. But obviously that picture differs by age. So again, this chart looks quite similar to the population chart that we saw on the previous slide. And that's what we'd expect, because we fixed our baseline utilisation and we're just rolling that forward to the thing that's changing, which is the population that we expect in future. In doing this, it's really important to note that we aren't taking any account of things that might increase the sort of utilisation of community services. We're not looking to meet any unmet need. We're not looking to deal with any efficiencies. Equally, we're not looking to reduce the utilisation of community services through any potential efficiencies. We're simply rolling the current utilisation forward into the future. So on the previous slide, we saw the change in community contacts by age groups, but behind that, we obviously have this very granular data set. So we're able to also look at the change by other factors. Here, we're showing it by the type of community team, and actually there's a quite a long list of community teams, around about 60. So we're just showing the top 10, those with the biggest increases, and the bottom 10, those with the lowest increases. So as we'd expect, really, the increases, we tend to see those in the teams that we normally associate with care for older people, and then the decreases we see more generally in the teams that care for children. But there's a key point here, perhaps, as well, in terms of workforce, obviously really important to any healthcare setting, but how the skill set and the staff and their sort of services that they provide might need to shift as we move to 35-36. So I have now a final slide on demographic growth. So we were really interested to see how our 20% overall figure for community contacts would compare to the demographic growth that we would see in hospitals. So luckily, we have available to us at the strategy unit our work on the new hospitals programme, and that is calculating the demographic growth in hospital settings. We've seen some slides of that slightly already from Fraser. But the methodology here is the same, and also the population projections, the ONS 2018 projections are the same as well. So it means that we're very able to make this comparison. And what we see is for any type of hospital activity, whether that's an A&E attendance or that's a hospital bed day, actually the pressures from demographic growth are not as high. So it looks like in community services, that pressure that comes from an ageing and growing population is going to be more keenly felt in community services. So, having considered the effects of the population or the demographic change, the next thing that we wanted to consider was the hospital activity, which might be expected to move out of hospitals and into the community. To do this, we used our new hospitals model, and this is something that we have available to us in the strategy unit. And the new hospitals model is concerned with forecasting demand for hospital care in future. And the NHP model, that includes several different factors or things that might influence demand for care, hospital care in future. So it has the demographic change. We just saw that on an earlier slide. It also has the non-demographic change. So non-demographic change, Fraser has actually alluded to this earlier when he was talking about these other factors. Often these are innovations, so new treatments, screening programmes, changing patient expectations, all things that can affect the levels of demand that we will see in future. But then it's a really key point for what we're trying to do here is that the NHP model also includes something which we call types of potentially mitigable activity. So this is activity which is happening in hospitals, which actually it's felt could be handled or taken care of in other settings outside of hospitals. So clearly, when we're trying to identify what could come out of hospitals, this is a really key piece of information for us. What I've done here, we've got 29 different types of potentially mitigable activity, which are community specific. That is moving care into the community. I've just summarised them on the slide here. So you get a sense of what they cover, and that they fall into these three mechanisms or levers by which change might be affected. So we have redirection or substitution, and then we have prevention, and then we have relocation. And it's really important that I flag our use of the word potentially. So when we classify activity into these different types, we're not saying that all the activity here would no longer need to go into hospital. What we're saying is that a proportion of the activity in these 29 different types is amenable to care outside hospital. That then leaves us with another question. How do we decide what those proportions are? Well, we have two different sources that we can consider here, or scenarios we call them. So because we've worked with many trusts as part of the New Hospitals programme, when they set their assumptions about what proportion could move out of hospitals into the community, we're able to take all those views and provide an average, which would then apply to every hospital in England. So we call that our planned scenario. That's something that feels feasible and that systems are already planning for. Then we have a second scenario. This is from an elicitation exercise that we did with a group of experts, where again they were asked to set their parameters about what they felt the proportions might be that could move out. But here there was a difference in that for them the resource or the capacity that would be needed is actually not constrained. So under this scenario it's much more far-reaching and ambitious, so we call it our ambitious scenario. So under those two different scenarios, what we see here is the activity that would be left in hospitals under each of those. So we have our do nothing scenario, which is actually, if there's no, we don't try and do left shift anymore, we just leave it as it is. So it shows us what would happen in that case. So in the do nothing scenario, we'd go from a baseline of 16.5 million admissions to 21.7 million by 2035-36. Under the planned scenario, because we're taking some activity out, that would actually be 20.2 million. And then under the ambitious scenario, where we felt we could take a bit more out, then that falls to 18.5 million. And it's really important, I think, to note on these slides, the shaded areas, they sort of represent the sort of distribution of possible values, and clearly they're quite wide, and that's because there is a lot of uncertainty here. And a great deal of the uncertainty actually comes from our non-demographic growth, our other factors, how those might play out over the next 10 years or so. So we've looked at admissions on the previous slide. Now we're looking at the same information, but for those for bed days, for those days patients spend in hospital. Under the do nothing scenario, they'd go from 55 million to 76.8 million. Under the planned scenario, that's lower, and it would rise to 63.5. But then under the ambitious scenario, any range of values there are below baseline, with our sort of central estimate of 46.6 million bed days. Then on this slide here, I've talked about how we would set the parameters, and these are set individually. So each of the 29 types of potentially mitigable activity, each of them would have their own parameter. So on the chart here, we can see the activity that we're assuming could come out. And we're seeing that under the two different scenarios. So you can see there's a broad case mix. For some it's quite large, for some it's quite small. For some there's a much bigger difference between the ambitious and the planned scenarios. So having considered, and we have quite a lot of detail about what we're taking out of hospitals, we need to think about what the effect of taking that out would be on community services. Turns out that's quite hard to do. It's not straightforward. We found a lack of evidence really here that could help us in this work, but we did find a report from Monitor back in 2015. And in the Monitor report, they factor in things such as numbers needed to treat, so the number of patients you'd need to see outside of hospital to stop admissions, and also the cost to setting up these out-of-hospital services. And in the Monitor report, there's a conclusion that actually after about 5 years, these costs are break even. And for us, that gave us an assumption of cost equivalence. So for every pound that we take out of hospitals, we would need to put a pound into the community. So then we wanted to think about what was the cost of the activity that we were taking out of hospitals. When we looked at that, we could see that in total, under the planned scenario, actually that would come in at about 4.6 billion costs coming out of hospitals. And then obviously the ambitious scenario, the figure is higher. It's about double. And actually under that scenario, 10.3 billion would come out of hospitals. So those are some quite large numbers, it feels like, but they're helpful perhaps to put some context around them and what they might mean. So we then looked at what the baseline budget, the budget back in 22-23 was for community services. We found a few different sources of information. So we've got something from the Nuffield Trust at 7.8 billion. We've got something from a question to Parliament, 11.9, and something from NHS England that comes in at 12.3. So in our analysis, we felt that the 11.9 billion, the middle value there was what we would use. So we've used that to frame some context. What that context shows us on the chart here, you've got that baseline 1.9 billion back in 22-23. And actually, this is what the budget would need to be in 35-36 under those two different scenarios. So under the planned scenario, we need to add in an extra 4.6 billion from hospitals into the community. That would take the budget to 16.5 billion, an increase of 39%. Then, under the ambitious scenario, we need to add in 10.3 billion. That means the total community services budget at that point would need to be 22.2 billion, an 86% increase on baseline. But it's really important to not forget the beginning of the presentation when we also looked at demographic growth, and we identified that overall that was a 20% increase. So when we add in that 20%, that's an additional 2.4 billion on each of the scenarios. So the planned plus that demographic growth becomes an increase overall of 7 billion, up to 18.9, a 59% increase. And then under the ambitious and the demographic growth, it becomes 24.6 billion, and that's 107%. So under the ambitious and the demographic growth, it's more than a doubling of the current baseline in 22-23 budget for community services. So obviously the figures on the previous chart, those were the end point in 35-36. But here, my final slide is just to provide a bit of historical context. So we're looking at the budget as it was back from 2018-19 and how it might pan out in future as we move towards the end of the 10-year plan period. So that's the end of my presentation. I'll hand you back to Mahmouda. I think you might be muted.
You are definitely muted, Mahmouda.
Yes, typical, isn't it? I had to be the one to do it as well. No, that's really interesting. Thank you very much, Justine. And both of those presentations present a really interesting perspectives, and they're not there's not a dichotomy there, they're kind of blended, and there's obvious tensions in what you're both talking about there. But we've got some time now for questions, and I can see it's been filling up on the sort of sidebar as well, so please keep them coming. But we also had lots of questions in pre-submitted in advance, so I've kind of tried to do my best, and hopefully I've done it justice in theming some of the questions and trying to pick out like the things that people are really wanting to talk about here. And obviously, whilst those questions are coming in, I'll pick up a few of those. And so Fraser, I'm going to come to you first, because in all of what you've described, lots of people can relate to that in the chat and the Q&A, saying, you know, that there's that tug of war, we've been here before, so what? So one of the things that struck me with what you were saying was that gap. So what do you think we need to actually change the pattern that you've described?
That's a small question, isn't it? So how is the question, how would you reverse decades of policy failure? I mean, if you're trying to get a handle on questions like that, or at least I invariably end up looking around the place for international examples, because what I think I described in my presentation is sort of really almost intractable problems and trends that it's, to me, unimaginable that you could get a handle on that through specific schemes or programs. Like, however good your specific scheme or program will be, you are working against a very big secular trend. So in a sense, I don't think the answer is going to be in particular programs, although they will be needed, and perhaps we could talk about that. And I think moves towards neighbourhood health look excellent. They look like a step in the right direction in that sense. But if you look at what countries that have made progress on this policy agenda have done, they have gone at it with sustained, consistent, coherent policy work that has gone on over decades. I think the Danes are probably the best example in this territory, and Sarah Reid at Nuffield Trust has done some really excellent work looking, comparing the NHS to Denmark. And they have done things like, over decades, reshaping the hospital estate, like halving the number of hospitals, making them bigger and more specialist. At the same time, bolstering care for older people, bolstering local institutions so they can provide care in the community. At the same time, giving local authorities incentives to do work to help prevent admissions through to hospitals, so putting some contractual measures in place. At the same time, like laws about the amount of the proportion of the overall budget that can be spent on hospitals relative to community. So these are macro policy measures, huge policy measures. So whatever it is that we could do to reverse those efforts, it's going to be on a similar scale. It won't be at the level of the project or the programme. And then the other thing I just don't want to lose sight of is it's not as though we don't understand this problem. All of the policy initiatives that have come around over the years that I pointed to recognise the problem and then failed to address it. So everything of the type that we've attempted has, it looks to me, been underpowered. So I think I'm pointing to some really quite high-powered measures.
And carrying on with that sort of, so what then, because that seems a huge thing for just policy alone and just us alone and meagre sort of programs to address. But actually, carrying on with what, Justine, you were looking at there with the demographic changes and carrying on with what future demand could look like. So what, because a lot of people here at the moment are from ICBs or systems or working on programs or interventions. Thinking about your analysis and the work that you're doing, it is also on a macro level in terms of, like, it's looking at a whole population level. So what then for ICBs and local systems? How can they actually use this information? What do they do with it? What's sort of next for how we can better understand that problem, given what Fraser just saying, we've got a good grasp of the problem, and you've kind of presented lots of data supporting that. So yes, what next then?
So I think clearly we sort of had to do it really at that initial macro level to sort of understand the potential impact. But clearly it won't be delivered. Any changes in terms of patient care and more care outside of hospitals won't be delivered by one sort of national organisation. It's down to those local areas, so ICBs particularly. I think in terms of the actual delivery, you know, sort of going down a level, we have worked with an ICB where we've sort of done this report, almost this report for them just for their area. And that was really interesting because they took it down another level in that they looked at their localities, which are their sort of groups of practices. And obviously primary care has a big part to play in care outside of hospital. So I think that is that need to understand at that lower geography or that lower level. In terms of what might be helpful, so we do have a report, I'm sure we can share links after the presentation. We do have a report specifically for looking at the types of mitigable activity, because I think that's really key. Probably in an area you'll sort of know roughly, are you know, your demographic growth, are you an old population or a young population? But I think the types of potentially mitigable activity will be really key in terms of where the insights can come from. So we have a report that people can use to understand that a little bit more, and it breaks it down into ICBs as well, so they've got their trends and their change over time. So I think that's an insight perhaps that could help people.
Can I add a that? I don't want to underestimate the challenge that friends and colleagues in ICBs are currently facing, and probably the best summary of it is one that's not repeatable in this format, but was on the HSJ a few days ago, describing the situation that commissioning bodies find themselves in. But if the ambition as written in terms of strategic commissioning plays out, then there is an institution and an opportunity to get hold of some of the broad level analyses that Justine was presenting and some of the specific tools. We're trying to translate a whole load of this stuff down to particular tools for local decision makers. There is an opportunity to get this stuff and to translate it out into action. It seems to me that strategic commissioning demands a level of analytical sophistication that historically at least would be unusual, and that seems to me to create an opportunity. So there's ways in which some of the analytical work we're doing can cash out into practical local change.
Thanks, Fraser. And Justine, I'm going to stay with you for a while, because I know we've had these discussions for a while about what can analysts do? What's the analyst's role in this? We talk often about good analysis. You've spoken about the sources that you've used, the techniques that you use, the predictions that we're making. So in terms of the analyst role and the role of a good analysis, how can they be helping systems thinking about sort of this new model of care, or like this new program they're working on? How can we analysts actually support that and the work that needs to be done in the way sort of Fraser's describing there about on a local level?
Yeah, so I think, obviously my opinion as an analyst is that analysts have a vital role to play in this. So some of the things I think are helpful is for analysts to be able to help people understand their current situation and how it might change, and do it at that more sort of granular level. There's a piece of work actually which really interests me in the unit. So when we think about community services in terms of the data, it's this sort of giant and amorphous blob, and it's really actually quite hard to understand the patients and their needs. So we get the team types, but actually that's not that helpful. So what we've been working on is a technique for clustering community services. So they're clusters, they're sort of types of patient or types of packages of care. So the work that we've done there, rather than having everything under district nursing, it might, so actually this patient and their care is an end of life, because we know that we've got linked to their mortality record, and actually this patient, it's because they've got general needs, or this patient's got long-term condition needs. So I think that way of classifying community services is an insight that's really valuable that analysts can provide. We could look at demographic growth, sort of understand the packages that are needed, might be really helpful in actually sort of transforming care. I think as well, Fraser always encourages me to sort of peep out from behind the analyst, and maybe analysts should have their own views on sort of important questions. When I see the charts from the work where we've got those financial figures that we're predicting forward, I start to worry about the workforce. I was like, where would the nurses come from? Where will their offices be? Will they have laptops? So, all those things associated with meeting that demand. So I think sometimes it's okay for analysts to maybe raise the questions that they think that we should be investigating.
Thanks, Justine. And we always welcome and encourage that stepping out from behind the analyst, for sure. Fraser, it'll be amiss of me if I didn't address this, because we have plenty of questions about funding. What's the right funding model? What's the right financial model? How do we contract this? What's the governance around this? How do we do all this stuff? Recognizing that's been like a forever challenge, shifting the money, shifting care. So and we get it in almost every session we do. So I guess from your perspective, like what can we actually learn in from previous reform about how do we do that? How do we address that big, meaty problem that we get so many questions about?
I guess the first thing to do is to recognise that you are engaged in making trade-offs. So no, I don't think anyone on this call is going to think, oh, everything that goes on in hospitals is bad and everything that goes on in the community is good, and so what we need is less hospital. Literally no one thinks that, I assume. And so to the extent we're talking about more of one thing and less of another, we're talking about trade-offs. And to the extent that we're doing that in health and social care and extremely resource-constrained environments in many ways, the trade-offs are tragic. So if we're going to be engaged in having more of something, we're having less of another good thing. It's not that we're turning away from bad things, we're turning away from good things. So the first thing is to recognise and and just acknowledge the trade-offs that you have. I mean, I think the contractual stuff is really important. I think it matters, and it will be important to get neighbourhood contracts up and going. It will be important to, and we've done loads in the unit, haven't we, on outcome-based commissioning to work those things through. There are social finance models that are quite interesting. We should look at those. But this won't, again, I'm just going to sound like a broken record, this won't be fixed through particular contractual forms. If we're going to address the problem we're pointing to here, it's macro level resource allocation choices. So we might be looking at things like, you know, sort of like reshaping the way that innovation is funded and works and is harnessed, looking hard at the role of NICE and technology appraisals and what that does for resource allocation. We might want national level sort of program budgeting type exercises, but these are be really, again, really big macro resource allocation things supported by contractual forms, not leaving contracts to do the work.
And I think that's a really important question, because we get it's a response, because we get so many questions about it. One interesting question, actually, and it's been very popular in the Q&A, so I'm going to sort of put it your way, Fraser, because you might actually like it. But what sorts of innovation might actually drive or increase activity and investment in community services? A bit of playing the system there. So can innovation actually, could we find out the thing that might get the investment drawn?
Well, that's the trick. I mean, that it seems to me is a huge part of the trick, is you want R&D, research intensive, capital intensive, lots of bright people buzzing around inventing things. You really want almost as much of that as you can put your hands on. It seems to me that if you want to pursue this policy goal, you need to direct it. Left undirected, it's going to give you what we've currently got. The King's Fund, now this is my off ramp because there's only a few minutes left as well. The King's Fund are kicking off a bit of work to look at exactly that question, and I'm going down later in the week to get engaged with that with them. But it looks to me like that will be a huge big part of the answer. That will be a huge part.
Thanks, Fraser, and thank you, Justine. I'm mindful that we've got a few minutes, only a couple of minutes left, and we've had like lots of questions. But hopefully, just on the optimistic side, is we've got lots more coming up in the series. So a lot of the questions focused on what's the evidence telling us, what are good examples of this, and we've got some really interesting sessions coming up in the future, looking at the what we have learned from the evidence base, what we can or should be learning from evaluation if it's possible, or where there's gaps in that. We've got that coming up to address, and one really popular question in the Q&A has been about the change in social attitudes and public perception around this, and we've got another session around that coming up. We're inviting Minal to come from the Neighbourhood Health Programme and having a discussion with her about the theory of change around that. So I just want to say a big thank you really to Justine and Fraser for sharing your work so far, and we'll share the links to all those things in a follow-up email. And this session has really hopefully set the sort of framing for what we're looking to do here and the discussions we're looking to have. Lots of the questions we haven't addressed, we hope that the rest of the series does. And one thing to say is that 1 hour alone isn't going to help us crack all the different elements of things that people are sort of wanting to know about, wanting to explore, wanting to discuss. So hopefully they're all things that we can pick up at some point, or we're trying to address together. In the sessions ahead, we'll take these issues further, exploring things like risks of risk stratification, the theory of change that I've mentioned, and what it really takes to make this work within communities, what we can learn from other sectors, and importantly, how we actually measure whether care is truly shifting. And so we've got some of those really interesting sessions to come. And if you want to hear about those sessions, or you want to sign up to receiving any updates from our from the strategy unit on any of the work that Justine and Fraser have mentioned, plus we do a whole load more on the specific tools that they've discussed there, and always open to discussion. If you want to come along to more of these events or the CVs, please do sign up, and then you'll hear about them first. But I'm at my last minute, so I will thank you all for joining us today, and we hope that we'll be seeing you at the future sessions of the series. So thank you very much, and good afternoon, everyone.